Hello, and welcome to Voice of the Disabled, produced by Adapter Chicago Productions and broadcast by CAN TV, Chicago's public access television station. I'm Joel Margolis, your host, and with me today, I'm very pleased to say, is Dr. Ann Sheets, not only a physician of many years' practice, but also an activist, if I may say so,
I am, Joel.
in causes to improve medical care for all Americans, if I may put it that way.
Very well put, Joel. Thank you.
Now, Ann, I understand that you're active in at least one organization devoted to what is often called the single-payer system. Could you tell us, as a starting point, what is the name of the organization and what briefly is its program?
Well, Joel, I'm actually active in 3 organizations that are specifically devoted to that. So one is the Illinois Single Payer Coalition, which works for that at the state level, and most states have organizations working on this. Another is Physicians for a National Health Program, which is a national physicians organization working for this cause. And the third is Health Over Profit for Everyone, another national organization of all kinds of people working on this. And what we want to do is to transform the American healthcare system into one that is constructed around providing what people need in healthcare, not generating profits for anyone, doctors, corporations, anyone. And what we intend to do is to extend Medicare to every person who lives in this country, have it cover 100% of all care, and have people able to choose any providers that they want. And we know that this country has plenty of money that we can afford to do that and take care of everyone.
Now, when you say expand Medicare, is this what you mean when you and others sometimes use the phrase single-payer system?
Yes, those are equivalent as we use them. What a single payer means is that all of the money goes into one pot, and that one pot pays all of the bills for everyone. And the advantage of that is that it's so much more efficient than the multi-payer system we have now, where there are actually hundreds of different insurance plans that providers might have to bill. And that's a huge waste of money. We don't want to waste that money. We want to use it to take care of people.
Now, when you say a single payer and you say expand Medicare, does this mean in effect that there would be a government program of health insurance for all?
Exactly. A single government insurance program.
Okay. Now, would all citizens pay in an annual fee to this?
Well, there are various ways we might do the financing, and most of us prefer not to get into those details. We prefer to say, we know that we have plenty of money to do this, and there are multiple ways that we know that. One is that many other countries most other developed countries provide health care to all of the people who live there, and they do it much less expensively than we do. That's one way that we know. Another way that we know that some people prefer to refer to is that we spend many millions of dollars in waging war instead of taking care of people. We spend millions of dollars on corporate tax breaks. That money could go to take care of people. There's something called modern monetary theory, which examines how money is created, that says that the federal government does not have to have a revenue stream in order to provide programs. And we know that they don't have a revenue stream for war. Why do we need a revenue stream for healthcare?
Now, when you say other countries do it for less, are you suggesting that the countries that have either a fully socialized system, such as Britain, or a national health insurance, such as Sweden, when we look at those countries and we take the total spent on medicine each year and divide it by the number of people to come up with what we might call, if I may put it this way, a per capita medical expenditure, does that per capita annual medical expenditure per person come out lower in places such as Sweden and Britain than it does here?
Yes, it does. We're by far we have by far the highest per capita spending on healthcare of any country in the world, and yet we do not have by any means the highest outcomes in health.
When you say by far the highest per capita expenditure, are you suggesting that the amount of money spent per capita on medical care in this country? Is it something more than just 8% or 12% than the money spent in Britain or Sweden?
Well, there are a lot of differences among other countries, but if we take the average of the countries in the Organization for Economic Cooperation and Development, which are all well-off countries.
The OECD, as it's
OECD,
called?
right.
That's, for the benefit of our viewers who may not know, that's the organization of all Western post-industrial democracies, plus several other non-European countries that are economically developed.
Right, and the average among those countries is approximately half of what the United States spends.
The average for all of the economically developed countries per person per year on medical care is roughly half what we spend per person in this country?
That's correct.
To say the least, that's a sobering statistic.
Very sobering.
Now,
and it's one of the proofs that we can take care of everyone if we choose to do so.
Now, under the system proposed either by the Illinois Single Payer Coalition or the physicians group you mentioned, okay, does this mean that individuals would be forced to go to a doctor assigned by a state agency?
Absolutely not. People could go to any doctor that they chose, which is not the case under our current system, where your insurance company provides a list of doctors that they'll pay for. And if you don't go to them, you have to pay out of pocket the whole cost.
So we can have a single payer system, but people can still choose
Absolutely.
their individual physician.
Because all of the physicians, the hospitals, the dentists, everybody will be in the same system. You can choose where you want to go.
Now, suppose, for the sake of argument, that we have a single-payer system which provides for basic medical care for all people, okay? But some people argue, for whatever reason, that they want a level of care that the system does not provide. Suppose, for instance, that someone is a diabetic, okay, and wants to have the insulin pump, the implant whereby there's a surgical implant in the body that secretes insulin. Now, in the British system, the National Health Service, diabetics, of course, are taken care of through the traditional means of either insulin or oral medication or both, but the NHS will not pay for the insulin pump, okay?
Oh, I'm not aware of that. I don't know the details of what the NHS pays for or not. But there's no reason to exclude that. We don't plan to exclude that from our system.
Okay, but
By
if,
any
for
means.
instance, there was a certain care option that the single-payer system did not pay for, would a private individual be essentially forbidden to purchase that using out-of-pocket funds? Or if they wanted an alternative form of care, could they still purchase it using their own money?
Well, so what all insurance companies now, including Medicare, do is to develop, have some process by which they decide what will be covered and what will not be covered. So it is our vision that all medically useful care would be covered.
Now, when you say all medically useful care, you're talking about things such as visits to doctor's office.
I'm talking about I'm talking about insulin pumps, wheelchairs, and furthermore, we intend to include long-term care services.
Long-term care would
Absolutely,
be included?
that is our
Because one of
vision.
the greatest problems faced by millions of American families is having a very aged senior citizen who winds up in a nursing home for reasons that are simply beyond anyone's control, and they wind up not dying after a year or two, but living for many years, and the nursing home cost winds up impoverishing the family.
And we want to get rid of that. And the problems that person may have are beyond the control of the person and their family, but it is not beyond the control of our society to provide for that person to live in the community if they choose to do so, as most people do. And we know that's even cheaper than a nursing home. I mean, there the cost doesn't even enter into it because we're proposing something less expensive and that's more in accordance with what the person wants. We can do that if we
You're
choose.
saying then that not only you personally, but others backing the single-payer coalition envision a system wherein long-term care would be provided not in a nursing home for at least some individuals, but would be provided by things such as living at home with visiting
Absolutely.
nurses and the like. And you're saying
with
that
whatever
that
services you need.
and that actually would work out cheaper?
Yes. Absolutely. It would work out, it's cheaper for people to live in the community than in a nursing home. And it would be much cheaper to get rid of all the burdensome administration that people have to go through now in order to get those services.
Many Americans use the term socialized medicine rather broadly, okay? They will refer to something such as the Canadian system with the national health insurance as socialized, and I've heard many individuals speak of the Canadian system as if it were the same as the British system.
Right.
Now, to clarify this for our visitors, okay, in a national health insurance system, such as Canada or that of Sweden, are most doctors still employed as civil servants of the state?
I'm not as familiar with the Swedish system, so I don't know exactly how it works. But for instance, in the British system, all the National Health Service owns all of the facilities and employs all of the healthcare personnel. And they do have an opt-out for private care, which we do not anticipate doing. That's not part of our vision. But so what we're talking about is similar to regular Medicare that we have now, where the financing is socialized, but most of the provision of care is private, although we don't want to get rid of Stroger Hospital, for instance, and we don't want to get rid of the veterans system. And in fact, some people don't like the term socialized, but I think among younger people, there are many more who say, yeah, socialism, let's go for it. That's what we want.
Now, are there serious variations from one type of single-payer system to another? You mentioned that you're involved in several different organizations.
Right.
The Illinois Single Payer Coalition, the Physicians for a National Health Insurance System. Do most of those organizations vary on small details of care, or are there significant differences in policy in the way they would structure a single-payer system?
The vast majority of us have the same vision for what we ultimately want in our healthcare system. So many of the divisions are people finding ways to work together. So for instance, it's convenient to work at a state level. There are lots of things that you can do organizing within a state. And there are lots of things that a physicians group can do as physicians. So then there's National Nurses United, which is a nurses union that works as nurses. So it's more a way of figuring out the best ways to work together, but we are all working toward the same goal.
Now, when you say about covering medical care in a comprehensive sense, are you therefore suggesting that in a single-payer system, not only medical care in the narrow sense, but also dental care and optometric care would be
Absolutely.
included?
That's healthcare.
Okay.
It's an accident of how medical care developed that those are treated separately.
An accident, you mean?
In terms of that, medicine was advancing in one way, and and I by no means am an expert on the history of dentistry or vision care or that kind of thing, and dentistry was professionalized, I think, much later than medicine was. So, and it was the fact that that physicians started the first insurance program, and they really weren't thinking about dentistry or about people's vision, because the physicians who started it didn't do those things. But those are equally healthcare, as your heart. I mean, your heart, your eyes, your ears, your everything. Those are part of your body and part of healthcare.
So under the system that you envision, if we could take a specific of optometric services, someone who needed glasses, either nearsighted or farsighted, would receive the services of an optometrist.
Absolutely.
And the cost of the glasses would be covered by a single-payer system.
Absolutely.
To take that one step further, I'm sure as a physician, you understand something that some of our viewers might not, which is contact lenses, which many people see as purely cosmetic, may be worn by millions of people as a cosmetic device, but in addition, there are certain optometric diseases that require the contact lens. For instance, those who have the disease known as keratoconus, where the cornea is irregular, the glasses cannot provide sufficient correction, and the contact lenses were developed, many may not know this, originally to treat systems like that. Under a single-payer coalition, would even something such as contact lenses for those who need it medically be covered?
Those who need it medically, for sure. And as far as choosing between coverage for contact lenses and versus glasses for people who could use either. I mean, I think that's getting ahead of ourselves. I think what for us is important is that we would have a public process for making those determinations. It would not be something that an insurance company decides and it's proprietary how they came to the decision or even what they cover. We want all of this to take place in public, and people can advocate for that the system should cover glasses or contact lenses, whichever you want.
Now, you mentioned advertising by the pharmaceutical industry, okay? Although this is not literally a part of a single payer system, okay? I think this is something that will interest many of our viewers, okay? You're saying that at the present time, we have pharmaceutical companies not only advertising on television, or which is very well known, or radio, but you're saying that some of those advertisements are making false claims?
Yes, they may not, they're legal. I mean, I'm sure everything they say is approved by some lawyers, PR people, whatever. But they give people a very exaggerated sense of the benefits of drugs and a very inadequate sense of the possible side effects. And on the other hand, we fail to investigate and provide services for which we would not need drugs, that we could, take care of ourselves and each other better without using drugs. Pharmaceutical companies just have so much power, including in the federal government and the Food and Drug Administration. And they write their own reports on their studies. They conduct studies that are inadequate. So it's a very corrupt system, and it is an important part of the single payer system of Medicare for All, because it's important that our healthcare system provide care that serves people, not care that serves the investors and the pharmaceutical companies. So I have to draw a distinction here. I'm sure there are some people who want a single payer system simply because it would be, for instance, more efficient for their business, and they're not thinking in terms of public health. But as physicians and nurses and many other healthcare personnel, we are thinking of this in terms of a society in which people can live in good health. And that does mean that we don't put dangerous products on our farms, and that we have clean water and clean air, and that's a transformative vision of how we live. And that in fact we live in a world where we can expect our grandchildren to have a place to live as well as ourselves.
You not only practice medicine, you practice it in the trenches, if I may put it that way?
I did, absolutely.
Well, it sounds to me as if you very much know what you're speaking about.
I think I do.
I think you do too. I want to thank you for coming in today, and hope you'll join us again.
With you. Thank you.
I want to thank all of you in the audience for joining us today at Voice of the Disabled, just as I thanked our guest for today, Dr. Ann Sheets, who I think has provided a remarkable scope of information on a topic that concerns all of us. I'm Joel Margolis, speaking for Voice of the Disabled, produced by Adapter Chicago Productions and broadcast by CAN TV of Chicago. And I urge you, please join us again here at Voice of the Disabled.